Here's my disclosures. Consultant for Oral DNA Labs, Orogenics, KOL for Philips Sonicare, and I'm affiliated with Penwell Publishing. Anybody wants to write an article or a course, please see me afterwards. That's what I do. I facilitate continuing education courses. It seems like the more I learn, the less I know. And really what that is a comment on is how rapidly research is going forward. Brad Bale came up to me just after the lunch, after he finished presenting, the beginning of the lunch break, he said, "Is there enough new information since you were here 2 years ago today?" I said, "It's unbelievable. It's like I was not here. Even if this information were identical to what I heard 2 years ago, it's like drinking from a fire hose. You're trying to take all this in, and I understand that. I'm in attendance as well. But the point I'm making is the information is so new, and it's changing at a blistering pace that the more I know, it seems like the more I learn, it seems like the less I know." Just a very small historical perspective on oral systemic associations. I've been speaking about this from the podium for years, for over 10 years, and back then we knew a little bit, we thought we knew a lot, but we've come an extremely long way in a very, very short period of time. We used to talk, about oral systemic associations. It was all about CRP. That's all we knew. It was just about C-reactive protein. We now know that CRP is a marker, but the other things that we are listening to this morning indicate that our knowledge base is going through the roof. I mean, obviously more research will be done. So these are among the things that we now know, and I just try to put the information together and connect the dots. So doing so, periodontitis has significant infectious and inflammatory components. We all know this. These are facts. These are not theories. Chronic inflammation increases insulin resistance. Chronic inflammation and insulin resistance are major causes of atherosclerosis, which is the kickoff event for heart attacks and strokes. The science is very complex, but the concepts connecting the mouth and the body are not complex. It's really just this simple. These are the things that are occurring, among others. Let's look at periodontal disease, diabetes, and cardiovascular disease risk. Diabetes is the primary systemic risk factor for gum disease. Periodontal disease worsens glycemic control by increasing insulin resistance, and insulin resistance is the biggest root cause of atherosclerosis. And atherosclerosis is the kickoff event for cardiovascular events. So again, it's not the science is very complex, but the concepts are not complex. It really is just this simple. Conveying this information to our patients in terms certainly that they can understand should not be a great challenge. Everybody in this room I know is a very, very good communicator with our patients. Other research we now know, periodontal pathogens independently associated with atherosclerosis, independent of periodontal disease. So we're talking really about two different causality mechanisms. We're talking about periodontal disease and the inflammatory components of that and the infectious components, and we're talking about the periodontal pathogens independent of periodontal disease. So there's lots of things going on here. Connecting the science and the clinical, these are the 12 classic risk factors for periodontal disease. You know all about all these: smoking, stress, nutrition, heredity, diabetes, and so on. All of these are contributing factors. Not one of them is a causal factor. How you picked your parents cannot give you periodontal disease. Diabetes cannot cause periodontal disease. Smoking cannot cause periodontal disease. Biofilm coming out your ears cannot cause periodontal disease. It is the interplay between the bacteria and the body's response to the bacteria in a genetically susceptible individual that causes periodontal disease, period. That's the only thing. I'm going to repeat that. The proper bacteria, the periodontal pathogens, the body's response to the bacteria in a genetically susceptible individual. Those are the only things that can cause periodontal disease. So all these risk factors are contributing factors. They're not causal. The number one most important, bar none, risk factor for periodontal disease are the specific causative bacteria. Without these bacteria, disease will not occur. If the disease does not occur, the inflammatory response is not activated. The whole key is knocking down bacteria. Here's how we know the causative bacteria. These words were written by Dr. Sig Sakransky, who passed away very recently, and Dr. Ann Haffagey. The ultimate risk factor for an infectious disease is the causative agent of that disease. Without that agent, no disease will take place, no matter what. That is their emphasis, not mine. Without that causative agent, no disease will take place, no matter what. It is absolutely central to bacteria. We don't have to read through all this. Just look at the conclusion on the bottom. Pathogenic bacteria are better predictors of disease progression than clinical signs. Looking at pocket depths, bleedings, all the clinical parameters we look at, this is all we have known historically in the dental profession, but we now know that, in fact, bacterial markers are much better predictors of disease progression than pocket depth, bleeding upon probing, mobility, and so on. Microbiological diagnosis is the only procedure that provides evidence of etiology. And what I'm going to do is I'm going to show slides of cases. These are patients of mine. In fact, one I put on the slide deck 5 o'clock this morning because I just got these test results, and indicate the way in which this has changed the manner in which I practice. Finally, for the first time in 30-plus years of practice, for the first time ever, we now know exactly what we are fighting. Most of our careers, we've been guessing at it. We don't really know specifically what bacteria we are trying to control. I'm going to just go over briefly these. Anybody doing salivary diagnostic testing? Oh, that's a huge proportion. That's awesome. For those who are not doing testing, I just want to explain this procedure in the test report. Salivary diagnostic technology is one in which we get a salivary sample from the patient, and then we send it in for testing to oral DNA labs, and we get a report. This is the report. I'm going to explain it, but I do have to tell you a quick story. When you're getting the sample of the saliva, in the test kit there's a little bit of sterile saline. You put the sterile saline in a Dixie cup, give it to the patient, they rinse vigorously, you count it out for 30 seconds, and then you tell the patient, go ahead and spit out into the funnel, which collects it in the vial. I have a patient named Sue. I've been treating Sue for 20 years. And so we finally got bacteriological testing, and I brought Sue, and I said, Sue, we've been dealing with your periodontal disease somewhat successfully, sometimes not so successfully. I have this test now because it's going to tell me what it is I'm fighting. So I gave her the sterile saline. I explained it, I mean to say. I said, I'm going to put the sterile saline in a Dixie cup. You're going to take it in your mouth. You're going to rinse vigorously for 30 seconds and then spit it out. And she said, what part do I spit out? Just think about that for a second. And I adore her. I just adore her. I said, well, just spit out the sterile saline. Leave the rest in your mouth. Anyway, so you get this, you do this test, you get the test results, and here's the report that you get. If you can read that, you can see that the test report is broken up. Left are high-risk pathogens. This is AA, PG, TD, and TF. The middle 6 are moderate-risk pathogens, and the right one is 1 low-risk pathogen. So we're looking at 11 different bacteria. The black line represents the threshold of bacteria sufficient to cause disease. So you can see that if any bar graph is above or close to the black line, we have a lot of that bacteria, and those bacteria are causal for that individual patient's periodontal disease. And you can also see clearly that the black line is much lower for the high-risk pathogens. And it's much lower for AA than any of the others, meaning you don't need that much of those bacteria for aggressive periodontal disease to occur. So this is a patient of mine named Tom. Tom came in, he's in his mid-50s, he's retired. Tom has, as you can see pretty clearly, the PG, which is the second one on the left, above threshold, and TF above threshold, and the low-risk pathogens. So this is Tom. Now, this is the description of the bacteria that's on the test report. So I've just amplified this so we can look together. PG, Very strong association with periodontal disease, transmittable, tissue invasive, and pathogenic at relatively low bacterial counts associated with aggressive forms of the disease. The types of bacteria that the individual patients have indicate the treatment challenge that we have with a particular patient. We have patients with lots of AA or lots of PG. These are very difficult bacteria to eradicate, which is powerful information in terms of how we treatment plan these patients. When I have a patient with a profile like Tom's, I'm planning at the outset what I'm going to do for non-responding sites. Because he has such aggressive bacteria, I anticipate that the treatment results may not be optimal after one round of therapy, which again is very powerful information, helping me plan what I'm going to do for this patient if he doesn't respond to one round of therapy. So this is research that we have. Porphyromonas gingivalis is a significant predictor for acute myocardial infarction. Patients with PG are 13 times more likely to have a heart attack. Until now, we've had no clue what bacteria individual patients have had. This information has completely changed the way I approach dentistry in general, obviously periodontal disease most importantly. My whole thought process is completely different now because the science indicates that patients have this particular bacteria. They have a tremendously higher risk of a heart attack, but until now, I've not known specifically what bacteria each individual patient has had. So Tom, as it turns out, so what do? I see the test report. My first thought is not about his gum disease. That's now my second thought. My first thought is, what does it mean for his general health? So I go to Tom's health history and he has a family history. I was going to say thank goodness because another patient doesn't have. Tom has a family history of cardiovascular disease. So what do? I take the test report, I put it in his hand, and I say, next time you go to your cardiologist, give him this in his hand. Tom is now in a position to explain what the test report means. I want him to be his own advocate because it's a pretty high chance that his physician has no clue about this relationship between the bacteria that he has in his mouth. This is a member of an extremely prominent family in Philadelphia. Everybody in the Philadelphia metropolitan area knows exactly who this family is. This man's name is James. James has lots of AA and one other moderate risk pathogen. This is the description of AA, same as PG. Very strong association with periodontal disease, transmittable, tissue invasive, and disease causing at relatively low bacterial counts associated with aggressive forms of the disease. He has a very strong family history of periodontal disease. James comes in every 2 months rather than every 3. We practically browbeat him about home care. We put the tools in his hand to make sure that he can keep these bacterial populations as low as possible. This is the patient I put in at 5 o'clock this morning because this test report just came to me today. I am freaking out about Steve's case. I'm going to talk to Tom later because I don't know what to do with this guy. I mean, I'm sort of joking, but this information, when I get back to Philadelphia on Monday, first thing I'm going to do is call Steve. I just got your test report. You need to come in tomorrow. Patients with PG, 13 times more likely. He has AA up the wazoo, and he has PG, the red one, above threshold. He is at a significant risk for cardiovascular events. Yeah?
13 times, is that over the threshold, anywhere over the threshold, or
it's
PG at all?
The question is the 13 times greater likelihood of heart attack with patients with PG unrelated to the testing. It just says patients with PG 13 times more likely, unrelated to this testing. It was research unrelated to this. For most of my career, I've been of the opinion that only adults could have these types of periopathogens. Liz is 5 years old. Now you're going to be probably saying, what in... why would you possibly bacterial test a 5-year-old girl? Here's why. I met a fellow recently, maybe about a year ago. We just met, we started talking, what do you do? I'm a dentist, you know, I do some speaking, what do you speak about? And I just happened to mention, I said, I speak about the relationship between the mouth and the body. And one of the things I mentioned, I said just sort of matter-of-factly, I said, you know, there appears to be an association between periodontal disease, periodontal pathogens, and rheumatoid arthritis. And Will said, my daughter has RA, and she was diagnosed when she was 2, and she's 5 years old now. And because of this piece of research, this is why I said you need to bring your daughter in. For me to just have her spit in a vial, we'll make a game out of it, it's kind of funny, and so on. She doesn't have to be nervous, but it's because of this research. P. gingivalis initiates RA in genetically susceptible individuals by increasing autoimmune responses. The point I'm trying to make is my whole thought process as a dentist is now about what else is going on in the body. My whole philosophy of practice is now centered on what else is happening in the body. And it's because of this that I said to Will, I didn't say you have to bring your daughter in. I said it would be a very good idea if you brought your daughter in, just for us to examine what's going on here. So he did. And that was her test report. She did not have PG above threshold, but she has AA above threshold. She does not have periodontal disease at all. She only has primary teeth. So there's no periodontal disease occurring, but she has AA above threshold. I called Will and I said, this is the test report, the report results. He said, how did that happen? How did she get that? I said, she got it from you and or your wife, your parents, your wife's parents, aunts, uncles. Transmittable. Remember, AA is transmittable, tissue invasive. We need to kiss our children, we do. But we're transferring this bacteria. He said, what do I do about this? And I made a recommendation for a power toothbrush because the power toothbrush I recommended has been demonstrated by DNA analysis, this testing, to knock down these bacteria very, very significantly. So I said, you get this brush for her tomorrow. And then you come in, I recommend, you come in, your wife come in, perhaps you have other children, they should perhaps come in as well, because this is not good. Unrelated to the potential for RA, this is not good. Pardon me? Somebody stole my line. I use that line. Everybody has periodontal disease. Must have heard me lecture before. That's my line. This, 2 more cases. This was Chris. Did not, but I'm going to. That's certainly something we're going to do in addition to testing the parents.
What difference would it make if you did? You already know you've got a problem. You're going to treat her differently if she's IL positive?
Yeah. The question is, am I going to treat her differently if she's IL positive? Yeah, that's powerful information, indicating that she's significantly predisposed, which would affect her monitoring and maintenance interval and potentially the home care implements that we put in play for her. The number one most important thing we do as dental professionals, in my opinion, is make sure patients have the tools they need to knock down the bacterial populations. It's all about bacteria. Make sure they have and they know. In fact, that's very relevant to the case I'm going to show you. 2 more slides, 2 more cases. It goes directly to that. Esther, in fact, I read an entire column in dental economics on this case. Esther prevented for dental clearance prior to cardiac surgery. She's going to have one surgery in which her heart was literally filleted open. They're going to replace one valve and repair the other valve in the same surgery. So Esther came in. She's 63 years old. I've only been treating her for about 7 or 8 years. And she has historically had very poor oral hygiene. She wears an old-fashioned cast metal partial denture, perio case type 4. Now, I'm a general dentist. I'm not a periodontist. I practice in suburban Philadelphia. the cardiologist said, whatever happens, you cannot have surgical treatment. You cannot have any type of surgical treatment until you have this cardiac surgery and you're healed from that and we get the results from that. So she could not have been treated surgically. So here's her test, and I'm really unhappy about this because she has 3 of the 4 high-risk pathogens above threshold. I gave her this test report because she was going to her cardiologist the next day. And I said, give this to your cardiologist. And to my surprise, he called me up. And he said, I'm Dr. So-and-so. I don't know how to read this report. So we spent about 5-10 minutes going over it, not line by line, but the high points. And here's what I said. I said, I cannot put my signature on a piece of paper that indicates she is cleared for treatment for the surgery until I provide periodontal treatment and retest her. And that's going to take 84 days because it's 1 week of treatment and antibiotics. You cannot do the post-test. You cannot do the bacterial test again until the patient's been off the antibiotics for about 6 weeks. So I said it's going to be 84 days until I can put my signature on a piece of paper that says she's cleared. And he said, this is a life-threatening surgery and I'm not proceeding until you tell me she's ready to go. And let me tell you that that was probably the most humbling experience of my career. Enormous responsibility, enormous opportunities. So here's what we did for Esther. I threw the kitchen sink at her. By the way, the DNA test report tells you specifically what antibiotics are effective against that particular combination of antibiotics. So there's no guesswork. It tells you exactly what antibiotics to use. So we did scaling and root planing, irrigation with 10% povidone iodine straight out of the bottle. And I do that because Tom Neighbors told me that's what he used to do. And that's why I do it. We used the Reston systemic antibiotics, as you see here, which came straight off the DNA test report. I didn't have to guess at it. Sonicare, Proxibrush, Floss, Listerine. This might have been the most important part of the entire treatment plan. We spent 1 hour going over every single aspect of home care. We put the tools in her hand, and we made sure she could use them. For instance, she had some teeth that were tipped or drifting, so she needed to use a Proxibrush at certain angles. We made sure that she could do that. And for the first time in her life, she understood the importance of home care, and in her particular case, it was for her survivability, not for her oral health. So, and this is wrong. The last line is wrong. We monitored her every 7 days for 4 weeks, and then we saw her 2 weeks after that. I made her bring in all her tools, bring in your Sonicare, bring in your Proxibrush, bring in your Floss, everything you bring it in so that you need to demonstrate to us exactly what you're doing. And she did it. She came in as exactly as we indicated, and we treated her, and we post-tested her 84 days later, and here's where we got to. Here they are side by side. This represents 90% bacterial reduction. Clinically, she was pristine, absolutely pristine. I could treat for another 6 months, and that TF is probably going to stay right where it is. 90% reduction. So when I got the post-test, she was in the office, and I handed it to her, and I said, congratulations, I can now sign off on your clearance. And she said the following. She said, I did it, meaning herself. She wanted the credit, and she deserved the credit. I said, yes, you did, Esther. Your efforts absolutely made the difference. The treatment we provided was important, not nearly as important as her bacterial reduction from her home care efforts on a daily basis. I don't have some slides in this slide deck, but there's newer information that says the following. It says that by the time the patient walks out the door of our offices, the salivary pellicle that precedes biofilm formation is fully formed by the time they walk out the door. In 1 hour, 60 to 90% of oral surfaces are repopulated with the bacteria. In a matter of hours, only hours, the biofilm is fully anaerobic, mature, and pathogenic in only hours. I used to say from the podium 3 to 12 weeks. We now know it's about a day, which is terrifying. This points out to me, this is a slight digression. It points out to me, in an hour-long hygiene appointment, should we be spending the last 10 minutes giving every last speck of calculus off or doing home care instruction? That's what I'm doing in my office now. Hygienists are going to be doing the last 5-10 minutes on home care instruction because that is more important than chasing the last speck of calculus. I'm not saying leave tons of calculus down there, but this research has such important implications for what we do for our patients. This is the last case I will show you. This is a friend to lots of people in this room, Dr. Chip Whitney. He's, thank goodness for me, he's in my area. And this case is way beyond the curve, but it is fascinating to see what this was about. Dr. Whitney has a patient named Barbara. He's been treating for 4, 5, 6 years, and she came in annually for a physical, and he did neurological testing every year, and every year neurology testing came up fine. Finally, the daughter, Barbara's daughter, became concerned because the mother seemed to be having some memory loss. So she contacted Dr. Whitney and said, I want to bring my mother in because I'm concerned about developing dementia. So Barbara's an 81-year-old edentulous patient. The patient's daughter contacted Dr. Whitney, concerned about the patient's potentially developing dementia. In fact, I wrote a column on this case as well. Dr. Whitney diagnosed vascular dementia, which is the second most common type after Alzheimer's, and it is caused by vascular events. Countless small asymptomatic vascular events that has a cumulative effect of memory loss. And the diagnosis of MRI, of vascular dementia was confirmed by an MRI. This is only about a year ago. She presented December 2011, or a year and a half ago, with significant memory loss compared to prior testing, atypical for Alzheimer's disease. Now, here's her blood panel and her other parameters. Her cholesterol was fine, her blood pressure was fine, well controlled, no insulin resistance, non-smoker. Look at her plaque 2 levels, 309, and normal's like 180, 200. You want it under 180 to 200. She had a plaque 2 level of 309. Typical causes of elevated plaque 2 include insulin resistance, which she did not have, other underlying inflammatory diseases, which she did not have, sleep apnea, which she did not have, and high-risk oral bacteria. Dr. Whitney is one of the few MDs in the country that is approved to do DNA testing, so he did her MyPeriopath testing, same as we've shown the test reports, and lo and behold, there it is. She's got AA and PG. Dr. Whitney indicated that the cause of Barbara's vascular dementia were these high-risk periopathogens. This is the treatment plan that we instituted. He instituted and I participated in. She's edentulous, remember that. Even though she's edentulous, these bacteria are anaerobic. That doesn't mean because there are no teeth, anaerobic bacteria cannot be there. This is not a theory. The testing indicated the presence of anaerobic bacteria. Underneath the denture base, in the tonsillar papilla, wherever, there are areas that are anaerobic. The posterior surface of the tongue, particularly if the patient has postnasal drip, is an anaerobic environment. That's where those VSC-producing bacteria are present on the posterior surface of the tongue. So the bacteria were demonstrated by DNA analysis. This was a treatment. She doesn't have periodontal disease. There are no teeth. If you don't have teeth, you cannot have periodontal disease. So here's the treatment. Full mouth disinfection with chlorhexidine. Swab all mucosal surfaces with chlorhexidine-soaked gauze for about 8 days, over and over. Spray the tonsillar area. Fabricate new dentures. The antibiotics as indicated on the test report. The treatment goals were to normalize plaque 2 and regain some cognitive function. It is unbelievably lucky for Barbara that she ended up in Dr. Whitney's office, because she at least has a fighting chance for regaining some cognitive function. If we did not have this diagnosis and this information on the causality, what would the physician do? Maybe increase the daily aspirin dosage, maybe prescribe Aricept, which is not for vascular dementia. It would have been basically good luck. I can't do anything more for you. This case it's way out there, but Barbara is unbelievably lucky that she ended up in Dr. Whitney's chair. Oral health is vascular health. As we all heard this morning, I mean, I've taken 12 pages of notes already. Oral health is vascular health. If every patient with chronic gum disease had the same subgingival microbiota, then a one-size-fits-all approach might be valid. This is absolutely, positively not the case. Everyone's DNA analysis of the bacteria is different. It's just like a fingerprint. Everyone is different. Treatment planning in periodontics is no longer based on probing depths, mobility, occlusal abnormalities, mucogingival defects, but rather is based on understanding the bacterial etiology and the patient's susceptibility to disease. Wellness versus end-stage disease model of healthcare. The end-stage disease model we've been practicing for eons, and it is a complete failure. Wait for the disease to develop, the heart attack, the gum disease, the stroke, whatever. Wait for it to develop and then manage the disease. That's a disaster. Let's try and prevent that. Identify and manage patients at risk prior to disease development. This is my second time at Bale-Donina, and I will tell you that I'm not being paid by them or anyone. I'm not being sponsored. But the information from just 2 years ago is so different. You come 2 years from now, it's going to be different again, as Dr. Bale said. Further research is going to affirm these relationships. There's no chance possible that the connection between the mouth and the body is going to be negatively affected by further research. The Bale-Donina philosophy magnifies the inseparable nature of oral and vascular health. Optimal care involves examining the patient's health history, family history, causal bacteria, home care, and so on and so on and so on, determining the likelihood of disease development and intervening early. I love the last line here. Unleash your hygienist. They're spending an hour with the patient. Their opportunity for education and information is absolutely superior to anybody else's in the dental practice. Optimal care is about the patient. Standard of care is about the provider. I finish with a little math test. Terry, you cannot give the answer away because you heard it on September 14th. 5 frogs are sitting on a log. Just sitting there, minding their own business, not doing anything special, just enjoying the day. 2 of them decide to jump off. How many are left? 3, right? There are still 5. Because 2 decided to jump off, and while deciding is important, it accomplishes nothing. Not a single thing. So at the conclusion of the day today, are you going to continue to sit on the log, or are you going to jump? Thank you so much for your time and attention.